Hello and welcome. My name is Jessica Adelman. I'm the Social Media and Communications Manager for the Ehlers-Danlos Society, and I will be your moderator today. For our webinar today, we have Dr. Peter Rowe presenting on Orthostatic Intolerance in EDS and HSD. This webinar is part of our ongoing series, Living with EDS and HSD. A quick note about how this webinar is going to work. Attendees are muted at all times. However, you are able to type in questions into the question box at any time. Dr. Rowe will not be able to see or respond to any questions until the Q&A time at the end of his presentation. Please do not send your question more than once, as it will not increase the chance your question will be answered. It will only make it harder for us to sift through these questions. Thank you so much for cooperating with us in this way. Dr. Rowe's clinical interests and research are focused on medical conditions characterized by chronic fatigue. His work first described an association between treatable circulatory disorders and chronic fatigue syndrome, and he has also brought to light several novel contributors to fatigue. These include connective tissue laxity and Ehlers-Danlos syndrome as risk factors for both orthostatic intolerance and CFS, the importance of milk protein intolerance as a contributor to symptoms in adolescents and young adults with CFS, an abnormal range of motion in soft tissues and nerves as a biomechanical contributor to CFS symptoms. His research has been funded by the National Institutes of Health, the U.S. Department of Defense, the Solve ME-CFS Initiative, and several smaller foundations, as well as by private philanthropy. He has directed the Chronic Fatigue Clinic at the Children's Center since 1996, where he is the inaugural recipient of the Sunshine Natural Wellbeing Foundation Chair in Chronic Fatigue and Related Disorders. He's also a member of the Autonomic Dysfunction Working Group for the Ehlers-Danlos International Consortium. Thank you so much, Dr. Rowe, for being here with us today.
My pleasure. Thanks to everybody for taking the time. Thank you, Jessica, for the invitation to bring out some of the information on this problem. We've been working on it for a little over 20 years now. And let's see if I can make that slide go. Okay, so this is the outline of what I want to cover in the next 45 minutes, and we are going to leave some time for questions at the end. The first is to talk about orthostatic intolerance, how we define it, what's really going on in the body, the physiology of it, some of the symptoms that we are attempting to treat when we treat orthostatic intolerance, and then a little bit on the different types of orthostatic intolerance, since there are several that are written about and that deserve our attention, especially in the EDS and HSD spectrum. Then the other thing, the next point, we'll look at orthostatic intolerance in EDS, a little bit on the evidence behind why it's got an increased prevalence. And then we'll spend the bulk of the talk on practical things that you can use to manage these symptoms. We think of orthostatic intolerance as one of the most treatable problems, both in EDS patients and in those with ME/CFS. So this gives us a lot of information, or it's at least a problem that we have a lot of information to use in trying to make people's symptoms better. So orthostatic intolerance is a term where orthostatic itself means upright. And orthostatic intolerance doesn't mean that you can't be upright at all. It just refers to a group of clinical conditions, not just one disorder, but a group of them in which symptoms will worsen when you're in a quiet upright position, such as sitting or standing. And those symptoms improve, although they aren't usually abolished by lying down. The big challenge physiologically is that when we move from supine to standing, we move about 500 to 750 milliliters of blood into the lower half of the body on standing. And I'll try and use my mouse to illustrate things. This is a cartoon from Philip Lowe's textbook on autonomic problems, showing the venous distribution when you're supine. And then with standing, there's blood that pools in the dependent arms and legs. The cartoon isn't quite as accurate as we'd like it to be with regard to how much blood pools in the abdominal circulation. It turns out there's quite a bit that does pool there. And the normal response to this is about a 10 or 20 beat increase in heart rate to get more blood up to the brain. And the brain sends out signals to improve the blood vessels' ability to constrict. and that returns blood back to the heart and to the brain. And usually this is accomplished fairly promptly. This is a better diagram of the normal physiologic response to upright posture from Rowe's book on cardiovascular control back in the 90s. Basically, when you stand, there's a bit of a reduction in arterial pressure. That leads to less stretch of nerves that are in what are called baroreceptors in the large vessels in the neck and the chest. They are usually used to being stretched as a sign that there's adequate blood going to the brain. When they're not being stretched as much, when pressure falls, that sends off nerve messages to the cardiovascular centers in the brainstem, and they respond with a big increase in sympathetic nerve activity. That drives up heart rate, improves the contraction of the heart, the stroke volume, and the biggest change that keeps us upright and conscious when we're standing is that the sympathetic nerves release norepinephrine, which leads to an improvement in constriction, and that then sends blood back up to the brain. If this doesn't happen normally, the brain almost overreacts. It keeps pouring out increased sympathetic nerve activity. You get much higher, progressively higher levels of norepinephrine and sometimes epinephrine, which then have their own consequences. If the person is not responding normally, these are the symptoms you get with orthostatic intolerance. So you get lightheadedness, syncope, diminished concentration, headache, blurred vision, fatigue, and exercise intolerance. And those are actually thought to be due to a reduction in brain blood flow. And that makes sense. We all think of lightheadedness and fainting as a reduction in brain blood flow, but that's probably also a lot of what contributes to the brain fog that people report so commonly. Headaches can be due to this. And in every form of orthostatic intolerance that I've encountered, patients with those disorders will report increased amounts of fatigue and exhaustion compared to their healthy peers, and they're often intolerant of exercise. The symptoms on the right are often due to this ramping up of the sympathetic nervous system response, so-called hyperadrenergic response. So you can get an orthostatic shortness of breath. Chest pain is very common, palpitations and shakiness. Anxiety is overrepresented in people with orthostatic intolerance. And that's in part because we can experimentally create anxiety and panic attacks if we drive up people's catecholamines, if we drive up their epinephrine and norepinephrine or similar substances in an experiment. So it's not surprising that anxiety would be higher in people with these disorders. You can also get an increased incidence of sweating and nausea and sometimes even vomiting. This slide and the next couple show you some of the common forms of orthostatic intolerance that we as physicians are looking for. The first one is called initial orthostatic hypotension, where there's a transient drop of at least 40 millimeters of mercury in the systolic blood pressure or a 20 millimeter drop in the diastolic blood pressure within the first 15 seconds of standing. This is transient, meaning that the person recovers from that. They might be a bit lightheaded and have dimming of the vision, but then beyond that, they're fine and they don't have chronic orthostatic symptoms. This is more common in adolescents. And because they don't have chronic symptoms, there's nothing one really needs to do in treating this, again, provided that they don't have other symptoms that I just showed you. This form of hypotension usually isn't detected unless you've got beat-to-beat blood pressure measures during the testing that you're having done. The second is orthostatic hypotension, which is defined as a sustained drop of at least 20 millimeters systolic or 10 diastolic, and also within the first 3 minutes of standing or of head-up tilt testing. This is much more common in older adults, but we can see it in adolescents if they've had an episode of vomiting, dehydration, or they're sick for some reason. Many of us will have had this very briefly when we're dehydrated, but this needs to be diagnosed in the setting well away from an episode of dehydration. Delayed orthostatic intolerance was emphasized by David Streeton, one of the grandfathers of orthostatic intolerance and autonomic research. He described it as orthostatic hypotension that occurs after 3 minutes upright. Then these are pictures of the initial orthostatic hypotension on the left and classical orthostatic hypotension on the right. Notice here that you've got blood pressure being recorded at the top, and as the person goes from lying flat to standing, they get a marked reduction in blood pressure that then recovers over a few seconds. This is time in seconds, so this is the 0 to 60 second period. And they might get a big increase in heart rate to compensate for that. Whereas with classical orthostatic hypotension, as soon as the person goes upright, blood pressure starts drifting down. And in older people, there's usually not much of a heart rate response. The more common things that we'll see in EDS patients and also in those with ME/CFS are postural tachycardia syndrome, neurally mediated hypotension, inappropriate sinus tachycardia, and there is a fairly high proportion who have just low orthostatic tolerance. We define POTS as a 40 beat increase in the heart rate in the adolescents. It only needs to be 30 beats per minute in adults, and this has to occur in the first 10 minutes of standing or head-up tilt testing. Has to be associated with chronic orthostatic symptoms and usually involves provocation of those symptoms during the 10 minutes upright. Patients cannot have simultaneous orthostatic hypotension. In other words, you can't have orthostatic hypotension in the first 3 minutes and get the diagnosis of POTS. We would just call that OH. Neurally mediated hypotension has a number of synonyms. This is the same physiology as people have with vasovagal syncope or neurocardiogenic syncope, but we termed it neurally mediated hypotension because not all of these patients have had fainting or syncope in regular life. But on the tilt test or the standing test, it's defined as a 25 millimeter or more drop in the systolic blood pressure, usually associated at the time of hypotension with a reduction in heart rate, which is the classic vasovagal response. Inappropriate sinus tachycardia has been recognized a bit more frequently of late. These are patients whose heart is not in a dysrhythmia. That is, they have normal sinus rhythm, but their heart rate is greater than 100 beats per minute at rest. They often have similar symptoms to those with POTS, and there's some discussion in the literature about how easy it is to distinguish these, but many patients with POTS have a more normal resting heart rate. The nice thing about recognizing inappropriate sinus tachycardia is that we have newer therapies for treating this that are much more effective than what we had in the past, the main one being ivabradine or Corlinor. And then lastly, I just want to emphasize that low orthostatic tolerance involves the presence of the same orthostatic symptoms as you might see in POTS and hypotension, but these patients don't have any changes in their heart rate or blood pressure during the orthostatic challenge testing. And there's some very interesting preliminary evidence from some Dutch cardiologists, Frans Visser and Linda van Kampen, to suggest that many of these individuals, even though they might otherwise be thought to not require treatment, actually have reduced brain blood flow that should respond to therapy. So I think their work, once it's published, is going to help validate the symptoms that many patients have reported. These are diagrams of the response in those with POTS on the left and hypotension NMH on the right. The one with POTS, this patient was supine for 5 minutes, stood for 10 minutes, and noticed that the heart rate in black goes way up, reaching a 51 beat per minute increment associated with the reproduction of their lightheadedness, fatigue, and headaches. Heart rate came back fairly promptly after resuming supine position. On the right is somebody who'd had a year's worth of fatigue, lightheadedness, pre-syncope as a medical student at Johns Hopkins. And this young woman was probably having increased symptoms because she was sitting all day in class. Notice that before the tilt, her heart rate was pretty normal. Heart rate only went up 9 beats per minute in the first 5 minutes of upright tilt, but she was immediately lightheaded and pale. And then at the 5 to 6 minute point, her blood pressure dropped significantly. Heart rate came down at that time. Normally, if blood pressure drops, we have a compensatory increase in heart rate, but this drop in heart rate is classic for the neurally mediated reflex pathway. And she even had some tonic-clonic seizure movements that can occur on the tilt test and in daily life when people faint. So that's the pattern that we'll see on tilt or standing test with these two disorders. One of the problems in the literature, though, has been that some people refer to POTS as the only form of chronic orthostatic intolerance, and that just doesn't fit with our clinical observations. And I think that notion is gradually disappearing from the literature, but you might find it in some of the older papers. And here's an example of why we say that. These two can occur together. So here's somebody who, during the first part of the tilt, gets a nice 40 beat per minute change in heart rate, so meets criteria for POTS in the first 10 minutes. Then heart rate keeps going up, and eventually that the whole process triggers a vasovagal or neurally mediated response at the 21-minute point. And we see this fairly commonly in our patient population. Let's move on to a slide that summarizes the main physiologic contributors to these orthostatic intolerance syndromes. Think of them as a combination of problems, one with a reduction in the person's ability to vasoconstrict when they're upright. That leads to increased pooling of blood in the level, in anything that's below the level of the heart. Second thing that's evident from the literature on these problems is that patients have about a 10% reduction in their blood volume when you measure them using fairly expensive nuclear medicine blood volume tests. Those are not done routinely. They're more reserved for research studies. But here you've got somebody who not only is a bit dry, has a reduction in their overall blood volume, but they can't get that blood back up from their legs and abdomen very efficiently. That then leads to this middle box of a marked sympathoadrenal response. So an increase in the sympathetic outflow from the brain and an increase from the adrenal gland as well. This is a term that David Goldstein prefers, and I like it as well. His research has shown that if you have more of a norepinephrine response, norepinephrine being a better vasoconstrictor compared to the epinephrine amount, that physiology might look like POTS. But if you have more epinephrine release, that has some vasodilating qualities, and that might predispose to syncope. But the arrow at the bottom is also important, given what we said earlier. That is, you can have POTS early and then have the neurally mediated hypotension pattern later. We'll come back to that slide when we talk about treatment. But for now, let's look a little bit at the evidence for orthostatic intolerance in those with EDS. We had originally noted back in 1999 that there was an overlap in our chronic fatigue syndrome clinic where most of the patients had orthostatic intolerance, and we were starting to see people with Ehlers-Danlos syndrome. So we put together our data with some colleagues, and out of 100 adolescents that we'd seen over a 1-year period, we identified 12 out of 100 who had EDS. So that was statistically significant in that it was much, much higher than one would have expected by chance just on the published studies on the frequency of EDS. At that point, 6 of them had classical type, 6 had hypermobile type EDS, most were females, all of them had chronic orthostatic symptoms, and we found that all of them had either NMH by itself, POTS by itself, or the combination. And all of them seemed to have their symptoms provoked when they were upright. Fast forward to 2014, there were a number of other papers in between, but some really excellent comprehensive work by Inge de Wandelay and her group in Belgium looked both at the autonomic symptoms in EDS patients and healthy controls and in their response to tilt testing. And you can see here, this wasn't a random sample of their EDS population by any means, but in a convenience sample, 94% of the patients with hypermobile type EDS reported symptoms consistent with orthostatic intolerance. And when they measured that more formally with an autonomic symptom profile, which gives you a score of a variety of autonomic symptoms, not just orthostatic intolerance, the EDS hypermobile patients were significantly more impaired than the healthy patients. When they went on to look at their tilt responses, that was also more common in the EDS patients. 74% had an abnormal tilt test versus 34% in the control population, and POTS was the most common form of orthostatic intolerance that they identified. So when we set ourselves on the task of looking at the overall literature on this problem, we noticed that there was a lot of variability in the methods between the papers. Among the issues that could cause different results were the age of the participants, the intensity with which the investigators looked for orthostatic symptoms, either by formal questionnaires or history taking. The duration and the type of orthostatic stress would differ from one study to the next. Some only did a standing test, others did a head-up tilt test that went on for varying durations of time. Some patients were even allowed to remain on the medicines for treating their orthostatic intolerance during the test. So that would have the effect of lowering the reported prevalence of orthostatic intolerance because you're partially treating them. And then the studies differed in terms of how much time fasting before they were put upright, what kind of sodium intake they were instructed on, the time of the day for testing. So we know that the morning, when patients are a bit more volume depleted, they'll have more orthostatic intolerance than later in the day. And then an important thing we look for is the amount of movement that the patients are doing during the test. We think that moving counteracts what we're trying to identify. And lastly, there's a referral bias in that all of these studies came from large tertiary care academic centers, and nobody's done a general overview of the prevalence of orthostatic intolerance in a non-referred population, which might give us a more representative estimate. But all that said, when we drew our conclusion in this paper that came out in 2018, and I would point out that Maria Roma, the student who was working on us that summer, herself has EDS. We concluded that in all studies with at least 10 patients or more than 10 patients, the data are consistent with clinically important and statistically significant increases in the prevalence of orthostatic symptoms and objective hemodynamic abnormalities in those with joint hypermobility or EDS. And the highest prevalence was found among those with the hypermobile type. Between 41 and 100% with joint hypermobility or EDS report orthostatic symptoms on a regular basis, with higher prevalence rates being reported in studies that had more comprehensive ascertainment methods for those symptoms. Heart rate and blood pressure abnormalities are identified in 56 to 80% of the patients in published studies, with higher prevalence again being reported when the testing duration exceeds 20 minutes. So this paper, I believe, is open access and people can take a look at it. It goes through all of the papers that we were able to find on this topic. So with that as background, let's look at how we typically manage these orthostatic intolerance symptoms. And we break it down into 3 steps. First are the non-pharmacologic measures that we can take. A second that is not often emphasized as often as I think it should be is that you've got to treat the other contributory conditions that that patient has. And step 3 is the addition of medications. We begin with monotherapy or single drugs, but usually we have to use different medications that tackle different aspects of that diagram I showed you earlier. And I call this rational polytherapy, meaning that you're really going after different mechanisms with each medication. So among the non-pharmacologic measures, the obvious one is, where possible, avoid the factors that precipitate symptoms. So if we go back to our diagram, we know that the problems are, you want to look at situations that provoke increased pooling, reduce volume, or lead to increased sympathoadrenal response. So the things that increase pooling or decrease volume are really prolonged quiet sitting or standing still. Things like with quiet upright posture. So those can include any kind of religious service, standing in line, being in line at the shops at Christmas, which would be a current problem. Even prolonged sitting in longer classes at school or college. Warm environments cause a reduction in the circulating blood volume to some extent because you're shifting blood to the skin to try and get rid of the heat. So our patients often don't tolerate hot days, really hot rooms, warm, hot showers and baths, and hot tubs. Sodium depletion can make this worse because sodium helps you hang on to fluid in the vascular space. Prolonged bed rest or deconditioning can make these problems worse as well. So we'll come back to that with another slide later. Older individuals who have varicose veins can often have increased pooling in these big dilated vessels. There's some evidence from the orthostatic hypotension literature that higher carbohydrate meals shift more blood flow to the gut, and that those patients do better with smaller, more frequent meals that are higher in protein and fat. It hasn't been studied that well or that formally, but this is an observation that patients often find resonates with their experience. We also want to look to make sure we're not giving patients anything that has a diuretic quality that makes them urinate more, that vasodilates the circulation, or some of the medications that we use for nausea are actually alpha blockers that block the vasoconstriction response. And then lastly, alcohol does two things. It will shift blood to the skin, causing flushing, and it'll also cause you to urinate more, so you lose more blood volume. So alcohol is often very poorly tolerated by our patients. Not by all of them, but many feel that they are very intolerant of even small amounts of alcohol, and as some describe it, they are cheap dates. The other thing is that if you're looking to reduce the hyperadrenergic component of these disorders, you want to look at things that cause increased epinephrine and norepinephrine, or increased catecholamines. These include stress of any sort. So psychological stress can make these symptoms worse. Doesn't mean the problem starts with a behavioral origin, obviously. Exercise and pain can aggravate these. Hypoglycemia can as well, and we often are referred patients who think they have recurrent hypoglycemic episodes, but really the response to hypoglycemia involves a big release of epinephrine. Well, that's also the response to being upright and not getting enough blood flow to the brain. So we want to look carefully to see if patients who've been referred with hypoglycemia really have that versus orthostatic intolerance. Among the things that will drive up catecholamines are catecholamines themselves, and we use them therapeutically in a lot of situations. Albuterol is used a lot in asthma. We often find that our patients who have asthma who are on albuterol feel very shaky after they get it. And so we try to avoid using albuterol when we can in the patients who have orthostatic intolerance. They don't need more catecholamines, they need control of that problem. And then epinephrine is sometimes used in asthma or allergic reactions. It's not surprising that some of our patients feel much worse after getting epinephrine. Among the non-pharmacologic treatment measures that are out there, an old one that was first published, as far as I can tell, back in 1944, is to raise the head of the bed. This seems completely counterintuitive initially, because you're already having trouble getting blood flow to the brain. But what this does in some ways is it reduces blood flow to the kidneys, so there's less production of urine overnight. There's an anti-diuretic effect, and blood volume tends to be better in the morning. Not everybody tolerates this. You can see that this man has a speed bump here to stop him from sliding down the bed. And as many patients say, it stops them from using their silk pajamas. More commonly, we can use compression garments. If blood is pooling in the limbs, you want to use something to kind of compress those limbs and push that blood back up. Among the things that are available are support hose or support stockings, and those can be as tight as 30 to 40 millimeters of mercury, but many of our adolescent and young adult patients find that those are just too much of a struggle to get on and off. And most of them tolerate better the 20 to 30 millimeter compression stockings. The waist-high stockings do better than just the thigh-high, and those do better than the knee-high stockings, but knee-high is better than nothing. Lately, and I would say in the last decade, there have been some more well accepted garments, the body shapers or Spanx garments, shown here on the right. And if they go from the upper abdomen to the upper thigh, those can be quite good at compression of the abdominal and thigh vessels. And many of the younger patients find that these are much more acceptable than the full-length stockings. Abdominal binders, which you see on the bottom and the right, are also helpful. Those are fairly inexpensive if you go on Amazon to look for abdominal binders, and they just Velcro around and provide some compression of the abdomen. Not everybody tolerates these, but many patients find them helpful, and they're not too obtrusive under the t-shirts. Cooling garments can help a lot with tolerating hot environments, and this shows a number of things that include neck wraps, cooling hats, towels, and vests, shown in the bottom right. Not everybody likes wearing these out in public because they call attention to the patients. Some of our patients who get a high heart rate when they're out in the hot summer sun will wear the vest when they come back into the house, and that helps them with their recovery. Postural countermaneuvers are things that many people use without even knowing why. So here's an example of somebody standing with their legs crossed. Other techniques include squatting, sitting with the knees brought up to the chest, leaning forward when they're sitting, putting the knees higher than the hips by putting the feet on a footrest, and then clenching your fists when you stand up. And the point here is when the vessels are not constricting adequately on their own, you're using the muscles that are on the outside of those vessels to pump the blood when the vessels won't do so on their own. The next slide just shows you a number of our patients and how they often find that they stand or sit. This girl's got her legs crossed and tucked under one another, so there's a lot of muscle tone there that you wouldn't have if your legs were just dangling over the edge of the bed. Many of them sit with their legs tucked under them. Some will tuck their leg under their bottoms even when driving. Fluids and salt intake are key in these disorders. We want our patients drinking at least 2 liters a day. Some advice suggests drinking up to 4 or 5 liters a day. I find that really interferes with caloric intake and can contribute to nausea, but the individual needs vary a lot. We want our younger patients drinking at least every 2 hours. We don't want them guzzling a lot before school and after school with nothing in between because they don't like going to the bathroom at school. So every 2 hours, that means they need permission to have fluids with them all the time at school. We also want people to avoid sleeping for more than 12 hours a day if they've got fatigue as part of their syndrome, in part because you get too dehydrated. You've got to break up sleep into smaller segments where the parent or somebody else awakens the patient after 10 or 12 hours so they get better hydrated, they move around, they can go back and nap if they've got that much somnolence, but they need to stay hydrated. We suggest increasing salt according to their ability to taste it. Not everybody likes the taste of salt, so they can supplement their salt intake with salt tablets. There are 2 common brands shown here, the Thermotabs and the Salt Stick brand, the Vitacium. The buffered salt tablets tend to be a bit less nauseating than the older 1 gram salt tablets. And then there are a variety of oral rehydration products that you can put into your fluids. Tri-oral is one, Cerolite's another, and Liquid IV. Nobody's done a head-to-head comparison of these, but you can try them and see if any of them offer any benefits. Many other forms of these are out there on the market, and this isn't intended to be an endorsement of one or the other. In terms of activity, which is often a controversial area, we want people, where possible, to avoid excessive bed rest and sleeping. We want them to start moving more, but for the really impaired patients, they've really got to begin slowly and increase very gradually as their symptoms allow it. Sometimes recumbent forms of physical activity and exercise can help at the outset. we are very wary about rigid advancement of graded exercise that doesn't take into account the patient's symptoms being exacerbated. So we like a much more flexible form of advancement. And we often believe that when you begin to manage the orthostatic intolerance with medications, that then enables the exercise. So I think it's unfair when doctors require patients to first be on a good exercise program before they'll allow them any medications. Our physical therapy colleagues, including Rick Violand here in Baltimore, and we find that when we begin manual forms of physical therapy, these can be a bridge to better tolerance of activity and exercise. But our message often is that complete inactivity is the enemy. And I want to show you a slide about why that is. In any experiment where people have been forced into complete inactivity or asked to be completely inactive to look at the physiologic consequences, you see an increased loss of plasma volume, which is going to make their orthostatic intolerance worse. This is from a study by Greenleaf and colleagues in NASA volunteers where they went up to 220 days on complete bed rest. Notice that within just about 2 to 3 weeks, you can get up to about a 16, 17, 18% reduction in plasma volume. 16% reduction in plasma volume, 15% reduction on a single day puts you in shock. So when this happens over 2 to 3 weeks, you're really in trouble. And this may be why surgical procedures or illnesses often provoke orthostatic intolerance syndromes. We want to treat the contributory conditions. The next slide covers a number of the common ones that we see with orthostatic intolerance. So anxiety, we talked a little bit about, shares some of the same physiology as orthostatic intolerance. And when you get lightheaded from being orthostatic, it makes people anxious, which might make them hyperventilate, which then makes the orthostatic intolerance and the brain blood flow even worse. A lot of patients have motility disorders and reflux. We find milk protein intolerance in about a third of our chronic fatigue syndrome patients who have orthostatic intolerance, so treating that can be important. In the EDS population, the last few years, we've seen an explosion of data on the presence of mast cell activation syndromes, and these themselves can provoke POTS and syncope. So it's really important to look for this in patients who have a lot of food allergies, a lot of medicines that they're intolerant of, rashes, hives, and redness everywhere. We don't have easily available and reliable tests for this, so sometimes this requires a lot of clinical judgment. We talked about a little bit about allergies and asthma aggravating this, including the asthma treatments. Infection usually makes orthostatic intolerance worse, so people recover more gradually from common viral illnesses. We find a lot of movement restrictions even in the EDS population. So it seems paradoxical, but people have excessive joint laxity, but focal areas of tightness in the muscles and postural imbalance. We think this really needs to be treated by people who are good with manual therapy. Patients with thoracic outlet syndrome, which is more common in EDS, often will report that they get arm fatigue when their arms are elevated, but they also get systemic lightheadedness and systemic fatigue. So treating the thoracic outlet syndrome can be a way of making this better. Migraines and chronic daily headaches are common in the EDS population, and we would need a separate webinar on this, but we see patients with neuroanatomic compression, so Chiari type 1, craniocervical instability, and cervical spinal stenosis. Those can all have a separate impact on autonomic function and orthostatic intolerance. So a careful neurologic examination is key. And then occasionally we'll see pelvic vein incompetence or ovarian varices that lead to chronic pelvic pain that gets worse as the day goes on, painful tampon insertion and intercourse, and these women were often blamed as being emotionally frigid in the past before people recognized that they had a tremendous amount of ovarian vein dilation and varicosity, and this can be fixed with interventional radiology techniques. So we look very carefully for that on history. Just another point, here's a young woman who had something like 30 episodes of syncope, usually without any warning. and would hit her head on the sink when she was going down. And the workup was not very revealing, and the treatments weren't very effective. But she had an abnormal neurologic examination that made us get an MRI of her cervical spine. And you can see here that this angle, the clivoaxial angle at the base of the skull, top of the spinal cord, base of the skull, led to a retroflexion of this area, and it was abutting the brainstem. So when she bent her head forward, she was causing more strain across this area, more pressure, which we believe may have led to the sudden episodes of loss of consciousness without any warning, and to multiple concussions and injuries. Once we had this MRI, we were able to look back at the history and realize that she was getting into problems with her fainting when she put her head down to splash water in her face and clean it, or to put things into the dishwasher or the washing machine. So by stabilizing her neck position and avoiding neck flexion, the syncope largely resolved. And she may elect to have surgery later on to correct this area of deformation. So it just points out that a complete history and exam is really critical in patients with orthostatic intolerance. Here's another one who had refractory POTS and very brisk reflexes. And you can see here, you don't need to be a radiologist to see that this disc is pushing back on the cord in two places and narrowing her spinal canal to 7 millimeters. It should be a 13 millimeter diameter. And you can see that the cord is actually thinner here. That's referred to as myelomalacia. She had an almost complete improvement in her POTS once this was recognized and surgically treated. We don't think these patients are by any means a majority of those with POTS and orthostatic intolerance, but in the patients who are refractory to all of the usual therapies, it's really important to do neurologic examinations and think about other anatomic causes. Okay, on to the medications. We've got a few minutes left. Again, we're going to go back to this diagram, and if people are having problems with their ability to vasoconstrict, it makes sense to use vasoconstrictor medications to overcome that. If their volume is low, we want to give them volume expanders. If they've got too aggressive a sympathoadrenal response driving up heart rate, we want to try and lower heart rate or decrease their ability to release catecholamines and for them to have an effect on the heart. So here are the medications in those classes. Midodrine, many people know about, is a non-stimulant vasoconstrictor. Any of the drugs that we typically use for attention deficit, like dexedrine, methylphenidate, Adderall, combinations of these classes can be very effective as vasoconstrictors. Even the drugs in the antidepressant class, the SSRI and SNRI class of medications, have some vasoconstrictor effect. And I think Blair Grubb in Toledo, Ohio, gets a lot of credit for making us all aware of that. Droxidopa is a newer medication. We haven't had as much experience with that. I'll leave that for others to comment on. Among the volume expanders, obviously there's sodium, orally and occasionally IV, especially in patients who are responding to nothing else. Fludrocortisone is a very good volume expander. Clonidine does so through a different mechanism. Birth control pills can be very helpful as volume expanders and drugs that help with the response to vasoconstriction. And Kathy Boehm first emphasized this. Kathy's in Toledo as well, that these can help with patients who have otherwise recurrent fainting. Desmopressin is a drug that helps you reduce your urine output, so you've got more blood volume when you wake up in the morning. And then among the drugs that reduce heart rate are the beta blockers, disopyramide. Some of the SSRIs reduce catecholamines at the central level, as can ACE inhibitors peripherally. Ivabradine is a newer drug that helps lower heart rate. Methyldopa has been promoted by the group at Vanderbilt as a helpful drug for reducing the problems with tachycardia in patients with mast cell activation. And pyridostigmine bromide has emerged in the last decade as another helpful drug for balancing autonomic tone. So you may next wonder, well, how do you select from among those? And out there are both algorithmic and individualized approaches, but I want to mention that we have no clinical trial data to support the primacy of one approach or one therapy over another for managing orthostatic intolerance in the EDS population. Most of the advice we give is based on our own experience, given that there haven't been organized multi-center clinical trials on most of these medications. But here, for example, is a diagram from the group at the Mayo Clinic for their treatment of POTS. Their non-pharmacologic therapy looks like what we've just gone through. Pharmacologically, they suggest that everybody get as first line either a beta blocker or midodrine. Their second line would be something like Florinef. Third line would be the SSRIs. Fourth line would be some of the others that we saw on the previous slide. This can be very helpful for physicians who are not too familiar with how to treat POTS. It gives them a guideline that's fairly easy to follow. I like more the individualized approach where you look at items in that patient's history and examination. So for example, if the person comes in with a relatively low systolic blood pressure, I'm more likely to try Florinef or midodrine as the first line treatment. If they've got a really high heart rate, above 100 at baseline, we would try a beta blocker and we might move on to ivabradine. You can look at other clinical clues. If you've got a patient who's licking salt off their hand or keeping a salt shaker at the bedside, Florinef ought to help them hang on to that sodium in the bloodstream. If they have headaches, well, beta blockers can treat both the orthostatic intolerance and the headache. So sometimes you're getting two birds with one stone. I find that if they have a family history of ADHD, the patient who has the orthostatic intolerance has some increased likelihood of responding to stimulants. That's more of an observation that needs to be tested. If they've got bad menstrual cramps or worse fatigue around the time of their menstrual periods, then birth control pills or Depo-Provera might be helpful. If you've got somebody who's got prominent anxiety, then one of the serotonin reuptake inhibitors or clonidine might be good. If they've got a lot of pain, then an SNRI like Cymbalta might be helpful as a first line. And then if they're hypermobile and we're positing that they've got a lot of orthostatic intolerance because their blood vessels dilate too much when they're standing, then a stimulant medication or midodrine might be good. And then lastly, if somebody's got a lot of wakes up a number of times at night to urinate, desmopressin might be helpful in that patient to help with blood volume. I would also mention that some of the newer scientific findings may make these treatment recommendations moot. There is a lot of interest in the autoimmune basis for POTS and some of the other disorders. And this is bringing new approaches to treatment. This is a group that published a case report of somebody with POTS and mast cell activation using IV immunoglobulin and other treatments. And in Europe, Carmen Scheibenbogen in Germany has used immunoadsorption, a method of removing abnormal autoimmune antibodies in patients with chronic fatigue syndrome and CFS. And the beta-2 adrenergic receptor antibodies would be expected to cause orthostatic or contribute to orthostatic intolerance. So as we look at the field, we may be seeing newer, more targeted therapies as time goes on. But to conclude, we have to understand that the management of this disorder requires a lot of attention by the patient and the practitioners to the factors that provoke symptoms. You have to be willing to try several medications before you find a good fit. And you need to realize that medicines can often treat the symptoms, but don't necessarily cure orthostatic intolerance, a bit like the approach we take to asthma. We don't set out to cure asthma. We just want to manage it so that people are functional. And the management of the orthostatic intolerance, especially in EDS patients, is one part of what needs to be a comprehensive program of care. So I want to thank those who have helped me and my program over the years. And I'll add some supplemental slides in the packet that Jessica is going to make available online that'll have references for you to look for. But let's stop here and see if people have questions.
Thank you so much.
Okay.
And we certainly have lots of questions. Go ahead and keep those coming in, and we will get to just as many as we can. First question that I have for you, we have a few people asking how to find a POTS or orthostatic intolerance specialist in their area, and how they would go about doing that, because you can't be everywhere, so we can't send everyone to you. So do you have any recommendations for people in that way?
It's a big challenge, I will admit. Remember that POTS was only described by Ron Schondorf and the Mayo Group in, I believe it was 1993 or 1994. And so a lot of us were trained in the era before this was known about. So many older physicians don't know about it, and it's not really a big part of many medical training programs yet. So it's tough to find somebody who can help you. I think often people do very well working with their internist, their pediatrician, their family doctor, just because there aren't enough specialists to go around. But if you need a specialist, if you've got a more complicated form of this, you can look at some of the support groups for things like EDS. There are POTS and orthostatic intolerance support groups, people who have support groups for mast cell activation syndrome, and often they'll know of practitioners in your area who might be able to help. There are a couple of websites that I'll include in the supplemental materials, but Dysautonomia International has a very good website with webinars and educational material that might be helpful to bring your own practitioner up to speed so they can try some of these medications. I find that as we walk through our colleagues, the various steps that I might take, they get more and more comfortable with medications. They already know, most pediatricians know quite well how to manage prescribing stimulants. Most people have familiarity with the beta blockers. So it's just a matter of walking them through how they can use them in this setting as well.
Thank you so much. Our next question is, how does caffeine affect all these things?
So caffeine is interesting. You've got to look at your own response to caffeine. Caffeine works both as a vasoconstrictor, but also as a diuretic. So it depends on which effect you get. It might be that with some nice vasoconstriction, you feel more alert, you've got less lightheadedness. If your main effect from the caffeine is it just jazzes you up too much, or it makes you urinate too much, you're not going to find it helpful. We don't have a strict rule about caffeine. It's really what each individual's response to it has been that guides us.
Can you speak a little bit about brain fog, how to explain it, and if there's anything that can be done about it?
Yeah, so we think a lot of the problem with brain fog is related to inadequate blood flow to the brain when people are upright. That can be when they're sitting or standing. A lot of our patients counter that by studying lying flat or studying where they're in a chair leaning back with their knees or legs up. That brings a bit more blood flow to the brain. We find that brain fog usually improves as you get the general orthostatic intolerance better. That's not it's not quite as easy as that, and that's not always the case. But we generally find that if we find something helpful for the lightheadedness, that should help the brain fog as well.
Do you have any experience with medical cannabis and orthostatic intolerance?
My colleagues in the Netherlands find that the CBD oil can be very helpful. That doesn't have the THC in it for a variety of symptoms with patients who have pain and fatigue. I don't think there's much evidence about medical cannabis for overall orthostatic intolerance, but I think there's better data with its use for pain. We use a prescription drug called Marinol or Dronabinol, which has a lot of THC in it. It was originally introduced for patients with nausea and vomiting with their chemotherapy, but it's on the market. And if we have patients with a lot of nausea or insomnia, sometimes that can be helpful. It can even help with headaches. You have to be a bit cautious with using it because there can be a cannabinoid hyperemesis syndrome where people get, when they're using it too much, they get excessive vomiting. And I think we need more formal studies to help guide us, but we've found anecdotally that at least a subset of patients have some benefits with their overall symptoms using cannabis products.
Can orthostatic intolerance or POTS generate a raised body temperature, like a low-grade fever? And if so, what can be done for this?
I don't know about the temperature elevation, but we very often hear as people are on the tilt test that right before they develop hypotension, they get a hot flash. And if I'm doing a standing test in the clinic and somebody says, I'm getting really hot, I want them down on the ground because they're about to faint. We think that some part of the physiology of the hot flash that they get is related to a surge in epinephrine. And again, that symptom usually gets better as we treat the orthostatic intolerance more effectively. I don't know about whether there's actually a true elevation in body temperature. It's often such a transient event that one wouldn't be able to capture it very easily with a standard thermometer.
Some people report having problems with high blood pressure with orthostatic issues. Can you speak a little bit about that?
Yeah, I think that was observed by some of the POTS researchers early on, that they would notice that as people stood, they would often get an elevation in blood pressure. We think that that's due to the increase in the catecholamine production, the excessive norepinephrine. And it's not uncommon to see as people are standing during one of our tests, as their heart rate is drifting up, they might also have a drift up in their diastolic and systolic pressures. That eventually those blood pressures will drop if they develop a fainting response. But in the early part of a standing test, that's not uncommon. We think it's part of this catecholamine sympathetic nervous system response to inadequate blood flow to the brain. So the hypertension usually is a secondary phenomenon.
Do you have any information about pelvic congestion syndrome and how that relates to all of this?
Yeah, so pelvic congestion syndrome is something we've had about 20 or 30 patients with this. It's usually these are patients who historically have been found to have lowish blood pressure, fatigue, and as I mentioned before, they get misdiagnosed with emotional frigidity because they don't want to have intercourse because it's so laceratingly painful. They can have low back pain, but mostly they have pelvic pain that is usually better when they wake up in the morning because they've been lying flat all night. And then as those veins are filled whenever they're upright, the longer they're upright, the worse the pain gets. It's not easy to identify on physical examination. You might get some tenderness over the ovarian areas, but it needs to be, you usually need a venogram to diagnose it. People will often want to see an ultrasound beforehand or an MRI of the pelvis just to make sure there's no other cause of pelvic congestion. But sometimes you need to move to a venogram if the symptoms are very consistent. And in the interventional radiology literature, something like 80%, maybe 90% of patients who have true pelvic congestion and these really dilated, tortuous ovarian veins, they'll get about 80 to 90% will get an 80 to 90% improvement in their pain. And our anecdotal experience has been that once you remove that reservoir of vessels where blood can pool using these catheter techniques to block off the varicose veins, patients often do better in general. So I don't know if that's because the pain is causing an excessive input of noxious stimuli to the nervous system that has autonomic consequences, or if it's more directly related to removing a reservoir of where blood can pool. But often their quality of life improves because the pelvic pain is much better. I don't know what the proportion is that have that in the EDS community. Usually pelvic congestion syndrome is seen more commonly in women who've had several pregnancies, but we've reported it in patients who've never been pregnant. And I think our preliminary evidence is that EDS is a risk factor for that because it's a risk factor for any varicose veins.
Have you noticed a link between dysautonomia and insomnia?
Many patients with either chronic fatigue syndrome, ME chronic fatigue syndrome, or EDS with prolonged fatigue have insomnia. I don't think anyone's entirely sure why insomnia is so often associated with these problems, but it's often a very tough problem to get treated. It may be that the autonomic tone is a bit high at night, so people awaken easily or can't relax enough to get to sleep, but it's not the patient's fault. It's something wrong physiologically. And I think it's an area that we need a lot more tools to treat.
How does altitude affect POTS? Some people report problems in plains or in higher altitudes and mountains or whatever. Is there anything that can be done for that?
People will have a bit of the cabin in the plane will have less atmospheric pressure, so there's less of an outside pressure on the legs, and that's why some of us, especially as we get older, will get a bit of swelling of the legs after a long flight, edema outside of the blood vessels. And so patients who are intolerant of flights, we will have them wear compression stockings, really get their sodium intake up higher that day. We've occasionally given people IV saline before they go to reduce the likelihood of a bad flare of their orthostatic intolerance after, say, a transatlantic flight. So there are a lot of things you can try that might help with that.
We have several people asking about CSF leaks.
Right, that's become an area of interest, especially in patients who have connective tissue abnormalities like EDS, that there can be spontaneous spinal fluid leaks that lead to less ability to cushion the brain from the skull. And those patients are very intolerant of upright posture, usually developing bad headaches when they're upright. So the headache can be a clue perhaps to the presence of low intracranial low intracranial pressure and a leak. It's been a tough one for us all to diagnose accurately, and often the testing is quite involved and needs to be with somebody who's got the ability to do lumbar punctures, infuse fluid, do various scans, and different kinds of ways of doing blood patches to stop the leaks. And they can be a bit tough to identify, but it's an area that's been clearly more common in those with connective tissue problems.
Can you speak a little bit about some gastrointestinal symptoms, either gastroparesis or things like IBS or bloating, and how that might relate to POTS?
Sure. The circulatory disturbance in people with orthostatic intolerance can affect the gut and its function as well. And we've had occasional patients who had prolonged nausea and vomiting that responded to treatment of their comorbid orthostatic intolerance. Again, it's often more complicated than that. Gastroparesis patients often feel full easily because they're not moving fluid out of the gut. And having a colleague in gastroenterology or a specialist in gastroenterology to help with management of that can be very helpful. We see about a third of our chronic fatigue syndrome patients who also have orthostatic intolerance have milk protein intolerance, and those people have a delayed response to milk protein. The cardinal symptoms that Dr. Kevin Kelly in Philadelphia first described back in the early 90s are epigastric or upper abdominal pain, reflux, and early satiety. So the sense that you take 2 or 3 bites of food and you're full, which couldn't possibly be the case, but that's what patients feel. About half of the patients we see who have that mix of symptoms will also have recurrent mouth ulcers. And those symptoms generally resolve within about 2 weeks of a completely milk-free diet. So that's one that I think needs to be paid attention to because it's so easy to treat. Irritable bowel syndrome is also overrepresented in these disorders for reasons that are a bit unclear, and patients with EDS can get stretching of the bowel wall and chronic constipation and poor motility from that. So there are a lot of problems in the gut. Patients with irritable bowel syndrome might respond to changes in their diet, such as the FODMAPs diet, to peppermint oil, and to other medications. So it's worth exploring that with your GI colleagues.
We have time for one more question. I apologize. We have so many questions here. Lots of people need to know about all of this. So thank you so much for doing that. Our last question is, how can we help our doctors who, if there's no one in the area who is considered a specialist, how can we help those doctors understand these conditions better and maybe convince them to order some of these testing and look into these issues more?
So I think that's where we have to rely on some of the materials that have been put out. For example, in the MECFS world, there's an adult primer and a pediatric primer that some of us worked on that came out last year. The pediatric one is open access, so anybody can download it. It's about, forget how many pages, 40 to 60, somewhere in there, a lot with appendices and things that are meant to make it easy for the physicians. And a lot of the material in there would apply to those who have EDS as well. The advocacy societies are also a very good source of information. What you don't want to do, I don't think, is give people a pile that's 2 feet high to read. Brief introductory pamphlets and brochures are often very helpful. Most physicians are really busy, but not but they'll be interested in exploring this with you. So I think doing it bit by bit might be helpful. And I think there are a number of people trying to put out webinars that help educate physicians on these topics. The CDC has a pretty good MECFS website. I'm not sure how much they've got on EDS by itself, but the EDS Society has good information there.
Thank you so much, Dr. Rowe.
Okay, my pleasure. I'll get some of the extra information to Jessica, and hopefully that'll give you some more resources at the end. Thanks,
Wonderful.
guys.
Thank you.
Okay.
Yes, as a reminder, this webinar has been recorded and will be uploaded within a few weeks on our YouTube page, and it'll be posted on social media. We will include the slides when we post this. So if you missed any information, you can look at those slides or this recording. Thank you all so much for being here today, and you have a great day.